Now we will discuss one surgical procedure for the recurrent instability of the shoulder, that is a coracoid process transfer. The prevalence of a recurrent instability after operative treatment has been reported to range from 8 to 18%. It is quite high. One of the reasons for such a recurrence is glenoid bone loss. Arthroscopic labral repair for the treatment of the anterior glenoid instability associated with substantial osseous defects has been shown to have variable results, and additional procedures may be needed. Arthroscopic labral repair for the treatment of anterior shoulder instability associated with the osseous defects has been shown to have variable results, and additional procedures involving transfer of the coracoid process can provide successful outcomes. CT scanning should be used for pre-operative planning and assessment of glenoid bone loss. Patients with more than 30% of the bone loss in the glenoid need bone graft for shoulder instability. Proper placement of the bone graft flush with the surface of the glenoid and within 10 degrees perpendicular to the face of the glenoid decrease the potential for shoulder arthritis and suprascapular nerve injury. Osseous defects can be categorized either an acute glenoid fracture or a glenoid bone defect due to attrition. Glenoid defects associated with the recurrent instability can be divided into three groups. Type 1 displaced avulsion fracture, type 2 malunited avulsion fracture, and type 3 erosion of the glenoid rim. Loss of the anterior-inferior aspect of the glenoid decreases the articular arc leading to recurrent instability. An inverted pier appearance of the glenoid suggests substantial glenoid bone loss. Investigators have defined the critical limit beyond which glenoid bone loss may lead to recurrent instability as 25% to 30% bone loss at the level of bare spot or 20 to 25% bone loss at the inferior glenoid surface. Coming to the biomechanics, a glenoid bone defect involving more than 21% of the glenoid width substantially decreases the force required to subluxate the humeral head in an abducted and externally rotated position. Loss of more than half of the anteroposterior diameter of the inferior portion of the glenoid decreases the resistance to anterior dislocation by more than 30%. The Letrajet procedure increased the glenohumeral stability by 350% and demonstrated maximum effectiveness in the 60-degree abducted and 30-degree externally rotated positions. In a comparison, a transplanted structural bone graft restored stability by 179% and had the lowest effect in external rotation at 60 degree of abduction. Structural bone grafting to restore the anatomy of the glenoid has been associated with good results. Autogenous iliac crest bone, coracoid bone or allograft may be used for this purpose. Autogenous iliac crest bone may be associated with additional morbidity. The Letrajet procedure, first described in 1954, involves transfer of a portion of the coracoid along with the attached conjoined tendon to the anterior or inferior aspect of the glenoid rim. This procedure has demonstrated reliable results when used for the treatment of shoulder instability associated with the glenohumeral bone loss and capsular deficiency. The coracoid process is fixed lengthwise and is held with the two screws. However, there is some confusion in the literature as the previous reports have described the results of Bristow procedure. The Bristow procedure involved transfer of only the tip of the coracoid distal to the insertion of the pectoralis minor along with the tendon. How does it work? It restores the AP diameter, It has got a slim effect to support the anterior-inferior aspect of the capsule, and dynamic contraction of the conjoined muscles provide a stability to the shoulder joint. Before doing surgery, you should know the basic anatomy of the shoulder, especially the coracoid area. In such cases, the mean coracoid transfer length is 28.5 millimeter. Mean coracoid height is 8 millimeter. Mean coracoid width is 13.6 millimeter. The musculocutaneous nerve penetrates the coracobrachialis muscle at an average of 56 millimeter from the tip of the coracoid process. The mean distance from the superior screw to the major branch of the suprascapular nerve is 4 millimeter. The screw placement be within 10 degrees of perpendicular to the face of the glenoid in the axial plane. The screw in the coracoid process is directed at less than 10 degrees from the glenoid surface to avoid injury to the suprascapular nerve. Technique for open lateral procedure. You have to go through deltopectoral approach, pectoralis minor, coracoacromial ligament should be released, osteotomy distal to the trapezoid ligament, subscapular split at the middle, glenoid should be prepared. Classical lateral procedure, inferior portion of the coracoid is transferred. Congruent arc method, lateral surface, place graft at 3 to 5 degree position, o'clock position, 5% recurrence rate. Malpositioning or a non-optimal position of the glenoid bone block has been recognized as a source of arthritis and shoulder pain. The glenohumeral contact pressure was optimally restored with the flush bone block. Bone blocks that were placed 2 mm proud increased peak pressure in the anterior-inferior quadrant as well as the contact pressure in the posterior superior quadrant of the glenoid. Graft placed in 2 mm recessed position led to increased pressure and edge loading in the anterior-inferior quadrant. Also, the inferior surface of the coracoid process provided greater surface area and increased congruity with the native glenoid than the lateral surface. Hill-Sachs lesion. A posterolateral humeral head defect, also known as a Hill-Sachs lesion, is commonly seen in patients with a shoulder instability. A defect more than 37.5% may require bone grafting. An engaging Hill-Sachs lesion is one in which the humeral head defect aligns with the anterior edge of the glenoid in abduction and external rotation, leading to shoulder dislocation. This type of defect can be viewed during arthroscopy and may be an indication for addressing the Hill-Sachs lesion along with the glenoid lesion. This concept may be more important than the size of the defect. If it is engaging, better to do a bone graft. These are some of the studies on the Latrajet and Bristow procedure. These procedures provide almost good to excellent results, and more than 90% of the patients are satisfied with the results. Coming to the complications. The rate of complications associated with the glenoid bone grafting, including recurrent instability or a neurological injury, has ranged from 5 to 25% in the literature. Traction injury to the musculocutaneous and axillary nerve is the most common neurological complication. The infection, graft fracture, humeral fracture, non-union, frozen shoulder, loose screw, nerve palsies, recurrent instability, subscapular weakness, hematoma formation, and graft malpositions are the complications reported in the literature. Coming to the conclusions and recommendations. Osseous defects in the glenoid are seen in patients with a recurrent anterior shoulder instability. The size, location of such defects are important factors to evaluate when determining possible treatment options. Substantial anterior glenoid deficiency can be successfully treated with the coracoid bone transfer. However, potential complications should be considered. Coming to the recommendations, patients with a more than 30% of the glenoid bone loss need bone graft for shoulder instability. There is a fair evidence for this one. Coracoid bone transfer is a safe procedure that is associated with a few complications. There is conflicting or poor quality evidence for this one. Improper graft placement may lead to shoulder arthritis. There is a poor quality evidence for this also.